Hi everyone. So today we'll be discussing a very important topic, that is treatment of differentiated thyroid cancers. A very important topic. Now, when I talk about this topic, I'll talk about the treatment protocol of differentiated thyroid cancers. But before that, I'll talk about the Tnm staging of these differentiated thyroid cancers, because it is very important to know the Tnm staging first to understand the treatment part of the differentiated thyroid cancers. And secondly, you get questions directly from the Tnm staging as well. The Tnm staging of thyroid cancers is important, and there's certain changes which have occurred in the Tnm staging of thyroid cancer in the 8th HSCC classification as compared to 7th HSCC. So that also we have to know. Plus, there are certain peculiar typical things in the Tnm staging of thyroid cancers. So that's why first we'll talk about the Tnm staging, and then we'll go to the treatment part of the differentiated thyroid cancers. So if I talk about the Tnm classification and staging of these differentiated, well-differentiated thyroid cancers, first I think all of us know that the well-differentiated thyroid cancers, they include the papillary cancer, follicular cancers, and the Hurther cell carcinoma. So we're mainly talking only about the treatment and the Tnm staging of these well-differentiated thyroid cancers. Now if I talk about the Tnm classification, starting with T, all of us know Tx is when the tumor cannot be assessed, and T0 is no evidence of primary tumor. Now, what is T1? T1 is a tumor which is less than equal to 2 centimeters in size and limited to the thyroid gland. So, it is limited to thyroid gland and less than equal to 2 centimeters in size. T1 can be divided into T1A and T1B. What is T1A? T1A is tumor which is less than or equal to 1 centimeter in size and it is limited to the thyroid gland, that is T1A. In case the tumor is more than 1 centimeter in size but less than equal to 2 centimeters in size, limited again to the thyroid gland, that is T1B. Okay. Then what is T2? If I talk about T2, T2 is a tumor which is more than 2 centimeter in size and less than or equal to 4 centimeter in size and limited to the thyroid gland. Limited to the thyroid gland, that is what is T2. Now, if I go to T3, this is something very important because this is somewhere, or this is a part where there's a change between the 8th HSCC and the 7th HSCC classification. What is T3? T3 can be divided into T3A and T3B. Now, what is T3A? T3A is a tumor which is more than 4 centimeters in size and again is limited to the thyroid gland, that is what is T3A. What is T3B? The tumor where there is a gross extrathyroid extension, or into the strap muscles. Gross thyroid extension into the strap muscles, that is what is T3B. Okay, so when it is invading, there's a gross extrathyroid extension or invasion into the strap muscles, sternohyoid, sternothyroid, omoid muscles, then you label it as T3B. Okay. Now, why I've been telling this is important is this is different from the 7th HSCC classification, Tnm staging. In 7th HSCC classification, what the difference is, in 7th HSCC classification, there was no T3A, no T3B, it was just T3, no A or B. And it was tumor more than 4 centimeters in size with a microscopic or a minimal extrathyroid invasion. So more than 4 centimeter size, microscopic or minimal extrathyroid invasion, that was T3 as per the 7th HSCC classification. But now we don't have that microscopic or minimal invasive. Now it is T3A, more than 4 centimeter, limited to the gland, or T3B, gross extrathyroid extension into the strap muscle. Then what is T4? Again can be divided into T4A and T4B. So definitely there has to be extrathyroid extension now. In T3B, extrathyroid extensions occurred to strap muscles. Now there will be extrathyroid extension even beyond the strap muscles. So T4A is tumor of any size if there is extrathyroid extension into the subcutaneous tissues or into the larynx or into the trachea or into the esophagus or maybe into the recurrent laryngeal nerve, that all will be labeled as T4A. So tumor of any size invading into trachea, larynx, esophagus, recurrent laryngeal nerve, subcutaneous tissue, that is T4A. What is T4B? Tumor has gone even beyond this. So if the tumor is involving the prevertebral fascia, or it is involving the or encasing the carotid artery, or maybe encasing or involving the mediastinal vessels, then it is called as T4B. That is called as T4B. Okay, so that is as far the T classification is concerned. Now, if I go and talk about the N, the lymph nodes, again NX is something where the lymph nodes cannot be assessed. Then N0, what is N0? N0 is no evidence of loco-regional lymph node metastasis. Now, there is something different here as compared to other malignancies, other Tnm staging. N0 we divide into two groups, N0A and N0B. N0A and N0B. What is N0A? N0A is that there is one or more than one cytologically or histologically proven benign lymph node. So there is a lymph node, but cytologically, histologically it has been proven to be benign. That is N0A. This is something different. Other malignancies we don't divide into N0A and B. Then what is N0B? N0B is there is no clinical or radiological evidence, of loco-regional lymph node metastasis. That is something called as N0B. Okay. More important to understand and remember is N1. N1 definitely is presence of lymph nodes. Which lymph nodes? Again, N1 can be divided into N1A and N1B. N1A is when there is enlargement of the central group of lymph nodes. The central group of lymph nodes, that's a pretracheal, paratracheal, prelaryngeal, delphin group of lymph nodes. And along with this, that means the level 6 lymph nodes. Along with this, N1A also includes the involvement of the level 7 lymph nodes. The mediastinal lymph nodes, now they have been in this Tnm staging, they have been clubbed with the level 6 lymph nodes. So both 6 and 7 is N1A. N1B is when there is involvement of the lateral lymph nodes, that is involvement of level 1, 2, 3, 4, 5 or retropharyngeal lymph nodes, that is something called as N1B. Okay. Now, again, one important thing is that in both N1A and N1B, these lymph nodes may be unilateral, may be ipsilateral or unilateral, or they may be bilateral. Fine. That is not going to affect the staging. That's not going to affect the classification. The N1A and N1B will differ with the which group of lymph nodes have been involved, which level of lymph nodes have been involved. It is going to depend on that. And in both categories, it may be unilateral, ipsilateral, or it may be bilateral. And why I'm saying N1 is important, it is definitely important. Plus, again, this is one I'll say category where there's a difference from the 7th AJCC classification. In the 7th AJCC classification, level 7 lymph nodes were a part of N1B. But now, as per the 8th AJCC classification, level 7 lymph nodes have become a part of N1A. Then comes M. M is simple. M0 is no evidence of distant metastasis, and M1 is presence of distant metastasis. So now once we have seen T and M separately, now we have to combine them, different permutation combination to determine the group staging for these differentiated thyroid cancers. Now let's talk group staging. This is also important because this is something very peculiar and definitely questions can be asked from this also. Now when I talk about group staging, why I'm saying it is peculiar, why it is typical? Because apart from T and M, the group staging of these differentiated thyroid cancer, this also includes the age at diagnosis. It also includes the age at diagnosis. Okay. So we divide patients into two groups. Patients which are of an age of less than 55 years and patients which are of an age of 55 or more than 55 years. So group staging is divided into two groups. For one group, one is for patients of an age of less than 55 years and one for those who have an age of 55 or more than 55 years. Okay. So if I talk about the first, the patient with the age of less than 55 years, in these we just have two group stages. Stage 1 is NET, NEN and M is 0. And stage 2 for these patients less than 55 years of age is NET, NEN and M is 1. So just two group stages, stage 1 and stage 2. For patients of these different thyroid cancers with the age of less than 55 years, stage 1 is NET, NEN, M0 and stage 2 is NET, NEN and M1. Keep this in mind, because, question can be asked on this. You may get a question on group staging. There you have to, see the age as well. Keep the age in mind, consider the age and then, mark your answer. If I talk about the patients with the age of 55 or more than 55 years, now here how do we do the group staging? Stage 1 is T1 or T2 disease, T1 or T2 disease with NX or N0, NX or N0, either of them, and M has to be 0. That is stage 1. T1 or T2, it has to be T1 or T2 or NX or N0 and M0. Then what is stage 2? Stage 2 can be again T1 or T2, N1 and M0. That is how we define stage 2. That is one definition of stage 2. Other definition can be it's a T3A or a T3B disease. T3A or T3B disease, that is T3 with any N and M is again 0. So these are two definitions of stage 2. Then what is stage 3? Stage 3 is, so we have done till T3B, so now it will be T4A. T4A, any N, whether it's N0, N1 and M0, that is stage 3. Then comes stage 4A. Stage 4A is, now it will be T4B, any N and M0, that is stage 4A. And the last one is stage 4B, any T, any N and M is 1, that is stage 4B. So this is a group staging for age more than 55 years, and for age less than 55 years, I'm repeating, we have just two stages, stage 1 and stage 2. So that is as far as the Tnm staging, the Tnm classification, the group staging for differential thyroid cancers. Again, I'm repeating, very important, questions are commonly asked on that. So you have to know the changes, you have to know the staging completely, the classification, the group staging, the peculiarities here, and the changes which are there from the previous 7th HSSC classification. Now let's go to the treatment per se for the well-defined thyroid cancers. Now, when I talk about treatment here, definitely I'm going to talk about the treatment protocol, the different modalities of treatment needed for these treatment of differential thyroid cancers, the protocol of treatment, plus at the same time, important part will also be the follow-up. How do you follow up these patients once the treatment is completed? So when I talk about treatment, it's just not treatment, but after the completion of treatment, how do you follow up these patients? So we'll discuss the treatment as well as the follow-up of these patients once the treatment has been completed. Now, if I talk about the treatment for thyroid cancers, the mainstay of treatment for thyroid cancer is surgery. Mainstay of treatment is surgery. Along with surgery, what are the other modalities which can be useful, which will be helpful in treatment of these different thyroid cancers? So another modality is radioactive iodine therapy. That's another very important modality. You know, we all know that these well-differentiated thyroid cancers, they are radioactive iodine avid. They have the ability to take up iodine, organify iodine. So they are radioactive iodine avid. That's why radioactive iodine therapy can play an important role in treatment of these well-differentiated thyroid cancers. And the third component of the treatment of well-differentiated thyroid cancer is TSH suppression. So we have three components for treatment of well-differentiated thyroid cancers: surgery to begin with, radioactive iodine therapy, and TSH suppression. So we'll see them one by one, and let's start with surgery. Now, when I talk about surgery for these differentiated thyroid cancers, the surgery would involve surgery of the primary, and management of the lymph nodes. So it will involve surgery of the primary and management of the lymph nodes. As far as surgery of the primary is concerned, for surgery of the primary, we will do thyroidectomy. And this thyroidectomy can be a total thyroidectomy. This may be a hemithyroidectomy. What we'll do, we'll just see after this. When do we go for total? When do we go for hemi? So we're going to do a thyroidectomy, which may be total, which may be hemi, which we'll see how to decide. And this thyroidectomy may or may not be accompanied by a lymph node dissection. Okay, for management of lymph nodes, this may or may not be accompanied by lymph node dissection. So that means what is important is every patient doesn't require lymph node dissection. Some patients require, some may not, and we'll see that again in details. In which patients we have to go for lymph node dissection, what type of lymph node dissection, all that we'll see. So first, let's talk about the treatment of the primary. First, let's talk about the thyroidectomy, and then we'll go to the management of the lymph nodes. Now, when we talk about thyroidectomy, that what type of thyroidectomy, whether total or hemi, will be done for a differentiated thyroid cancer, that depends on a lot of factors. But out of those factors, one very, very important factor is the size of the tumor, on which we decide, on the basis of which we decide that what type of surgery we're going to do for these differentiated thyroid cancers. Now, if the tumor is less than 1 centimeter in size, it's a unilateral tumor. There is no extra thyroid extension. There's no extra thyroid extension, and there is no lymphovascular invasion. No extra thyroid extension, no lymphovascular invasion, unilateral tumor, unilateral unifocal tumor, no extrathyroid extension, no lymphovascular invasion, these patients can be managed by, or one important accepted option of treatment in these patients is a hemithyroidectomy. Hemithyroidectomy, where we remove the affected lobe plus the isthmus, or we can go for lobectomy. So either of them can be done in these tumors less than 1 centimeter in size. Apart from this, one more option which we can have in this patient is less than 1 centimeter in size, which is unilateral, unifocal, no lymphovascular invasion, no extrathyroid extension. They are, all of us know, they are called as the occult thyroid cancers or micropapillary cancers. So nowadays, as the recent guidelines, the literature describes another alternative for these cancers, and that is active surveillance. We can go for a non-operative active surveillance in these patients of occult thyroid cancers or micropapillary cancers. Okay, so hemithyroidectomy for less than 1 centimeter. Another option can be active surveillance, where we are not doing any surgery for these micropapillary carcinomas. Now we talk about the tumors which are 1 to 4 centimeters in size. Now, tumors which are 1 to 4 centimeter in size, conventionally, we have been doing a total thyroidectomy. For any tumor more than 1 centimeter in size, we have been doing a total thyroidectomy. Okay, but now there's certain change in guidelines. There's certain recent guidelines which have been mentioned in your latest edition of Sebastian as well. Nowadays it is said that tumors which are 1 to 4 centimeter in size, if these tumors are unilateral and unifocal, if these tumors have no lymphovascular invasion, if these tumors have no extrathyroid extension, no capsular invasion, no extrathyroid extension, in these tumors of 1 to 4 centimeters with these features, these tumors can also be managed by a hemithyroidectomy. In these patients also we can go for a hemithyroidectomy. Why? Because these features of a tumor 1 to 4 centimeter make it at a low risk of recurrence. So tumors with all, tumor of the size 1 to 4 centimeter, these features, unifocal, unilateral, no lymphovascular invasion, no extrathyroid extension, they are at a low risk of recurrence. So they can be managed as per recent guidelines by a hemithyroidectomy. Fine. So hemithyroidectomy can be a option, or I'd say acceptable option in these patients of tumor size 1 to 4 centimeter if they have all these low risk features. Low risk of recurrence is there. So what are the patients, or what are the group of patients, or which are the patients where we will go for total thyroidectomy, or what are the indications of total thyroidectomy in patients of differentiated thyroid cancers? When do we go for total thyroidectomy? Definitely the first indication has to be any tumor more than 4 centimeters. So more than 4, you'll have to go for a total thyroidectomy. Then tumors with extrathyroid extension. So I can say T3, T4 disease, that becomes the indication of total thyroidectomy. Radiation-induced thyroid cancers. Now these thyroid cancers are aggressive cancers, so they should always be managed by total thyroidectomy. Then familial non-medullary thyroid cancers. Familial non-medullary thyroid carcinomas. Familial non-medullary thyroid cancers. So these are, also cancers which are aggressive cancers. So irrespective of size, here we should go for a total thyroidectomy. Apart from this, if the tumor is bilateral and multifocal, or if there is any evidence of metastasis. So these are the patients which should always be managed by total thyroidectomy. So basically, what is the logic or the scientific principle is, total thyroidectomy nowadays is an evidence-based surgery. So all those patients of thyroid cancer which have a high risk of recurrence, these patients should be managed by total thyroidectomy. Okay. There's one more, so they have high risk of recurrence, so total thyroidectomy will be a better curative option, will do a more curative resection. That is one which is advantage of doing a total thyroidectomy here. Second is that these patients who have high risk of recurrence, they will also need radioactive iodine therapy. I'll talk about that, which is the second part of the treatment. I'll talk about in a bit about the radioactive therapy. So they'll need radioactive therapy, they'll need a radioactive iodine scan, and for better utilization of this radioactive scan and therapy, we would require a total thyroidectomy. There should not be any remnant normal thyroid tissue. So that is how total thyroidectomy becomes advantageous in these patients. So that is as far as treatment of the primary is concerned, thyroidectomy is concerned. How do we decide which type of thyroidectomy to be done in which patient? Then the second part of surgery involves management of the lymph nodes. Okay, so how do you manage the lymph nodes? Now we know that thyroid cancers can involve the central group of lymph nodes, the level 6, level 7 group of lymph nodes, or they can involve the lateral group of lymph nodes. 1, 2, 3, 4, 5 group of lymph nodes can be involved. So let's first talk about the management of these central lymph nodes, and then we'll talk about the management of the lateral group of lymph nodes. So whenever we have a patient with a proven thyroid cancer, we preoperatively with clinical examination and sonographically, radiologically with an ultrasound, we assess the central group of lymph nodes. So you do ultrasound of the neck, to assess the central as well as lateral group of lymph nodes. Okay. So first I'll talk about central lymph nodes. So on the clinical examination or sonographic examination, central lymph nodes may be positive, may be enlarged, or they may not be positive, they may be negative, they may not be enlarged. Two things can happen. So let's first talk this scenario. On a clinical examination or a sonographic examination, central group of lymph nodes are enlarged. In these patients, along with thyroidectomy, we should always go for a central lymph node dissection. So if that means I can say that in a patient with thyroid cancer, if the central lymph nodes are clinically or sonographic enlarged, a thyroidectomy should always be combined with a central lymph node dissection. It should always be combined. Okay. Now, what about those patients where the lymph nodes are not enlarged, neither clinically nor sonographically? Now, in these patients also, some of them, not all of them, I'm reinforcing it, some of them may require a prophylactic central lymph node dissection. So, some of these patients where clinically, preoperatively, there are no clinical or sonographic evidence of central lymph node enlargement, but some of these patients will require a prophylactic central lymph node dissection. So what are the indications? That means which are these patients, or in other words, what are the indications of prophylactic central lymph node dissection in these patients with differentiated thyroid cancers? The first indication I can say is tumors more than 4 centimeters in size, tumors with extra thyroid extension, so that includes that means all T3, T4 tumors. And then very, very important is tumors with enlarged lateral lymph nodes, Now what can happen is, at times there can be skip metastasis to the lateral lymph nodes. Around 12% cases, there can be skip metastasis to the lateral lymph node. That means the central lymph nodes are not large and there are skip metastasis to lateral lymph nodes. Now in these patients, there's a high chance of occult disease in central lymph nodes. So in these patients also, a prophylactic central lymph node dissection should be done. Apart from this, two more indications of doing a prophylactic central lymph node dissection: in case the patient has a past history of radiation exposure to the head and neck, the history of radiation exposure to the head and neck, or it's a multifocal disease. So these are the indications of prophylactic central lymph node dissection, even if the central lymph nodes are not enlarged clinically or sonographically. Now, what about the lateral lymph nodes? So again, if we have a known case of carcinoma thyroid, Bethesda 6 or Bethesda 5, so preoperatively we have to evaluate, we have to assess clinically and sonographically. With ultrasound, we have to assess the lateral group of lymph nodes, whether they're enlarged or not. So on a clinical examination or a sonographic examination, if you find that the lateral group of lymph nodes are enlarged, we do a FNAC from these lymph nodes, and we find pathologically positive lymph nodes. In these patients, now what will you do? First thing is you have to go for a central lymph node dissection. We just talked about it. We just discussed that in case lateral lymph nodes are enlarged, automatically we will always go for a central lymph node dissection. That has to be done in case lateral lymph nodes are enlarged. Okay, even if central lymph nodes are not enlarged, only lateral enlarged, central lymph node dissection has to be done. And along with this, we'll do a modified, for the lateral lymph nodes, we'll do a modified radical neck dissection, which can be ipsilateral, which can be bilateral, depending upon whether the disease is ipsilateral or bilateral. So if you have ipsilateral disease, you do ipsilateral modified radical dissection. If you have bilateral disease, you do a bilateral modified radical dissection. Which type of modified radical dissection? Preferably type 3. Preferably type 3 because usually the extra lymphatic structures are not involved. So that is how you manage the lateral lymph node. But one important thing I'll just reinforce here is that there is no role of prophylactic lateral node dissection in patients of these differentiated thyroid cancers. We have a role of prophylactic central node dissection, but no role of prophylactic lateral node dissection. That dissection will be done only, MRI will be done only if the lateral lymph nodes are found to be enlarged. So that is as far as the surgical component of the treatment for thyroid cancer is concerned. With this, we'll go to the other components.